ZTCC. This is consent form where we determine which organs the family wants to give. And then, so before doing the second apnea test, here what we do is we inform the police that this is a MLC case, we are doing the apnea test, we don't take their permission. And after the organ retrieval, we have to hand over the body to the police again. At this moment, if we actually, at the potential donor itself, we get the transplant coordinators involved so that they can have a rapport with the families, and we start the hormone therapy at this point of time. The timeline, how much you want for the as in we have to wait for the ventilator, onto the ventilator. Usually it is 4 to 6 hours for intracranial bleed or the subarachnoid hemorrhage. For hypoxia, we have to wait for 24 hours. Spinal reflexes is something we have to be very, very careful about it, and it can occur in 50% of the patients. It can be flinging of the arms or just flexion of the trunk. Literally it appears as if patient is trying to sit out of the bed. Something which is incompatible is like decerebrate or decorticate posturing or seizures. These are incompatible with the brain function. Just one slide about the contraindication. So malignancy, if someone is cancer free for 5 years, is not a contraindication. Sure.
One suggestion is that instead of saying that the apnea test was positive, because it is actually a very negative outcome, I would recommend that the apnea test was suggestive of brain cancer. I think we should not in the country say that apnea test was positive. We should say apnea test was suggestive or confirmatory for brain cancer.
One comment. For patient on ECMO, you don't stop the sweep gas flow, you dial it down to 1.5 or 1 liter. We don't stop the... Yeah. No, that's the point. You can't dial it down totally to 0. What is recommended is this.
Dr. Manipal, can you, for the audience, tell us in a few tips?
The
diagnosed brain death on ECMO.
On ECMO, because ECMO is taken over the respiratory function, so you can't look at the CO2 if it is removing the CO2. The ECMO machine is removing. That ECMO machine is removing CO2 through the sweep gas flow. Now the sweep gas flow has to be dialed down to a certain minimum. It is not 0. It's down to 1 to 1.5 liters. If that is so, then it will reflect the respiratory function of the patient rather than what ECMO is doing.
Also, where do you take the ABG from, because the circulation now will be slightly different from the normal, right?
No, for VV ECMO you can take from the artery. Yeah. And another point is, when you do before apnea testing, the oxygen cannula should be above the carina. Right. It's not connected to the endotracheal tube. You put the cannula into the trachea above the carina. So these are the two. Otherwise, excellent presentation. I mean, it's you haven't missed anything. Yeah.
You said sodium of 120 to 160. Are you okay with the sodium of 120 while testing for brain death? Suril, what would you do?
No, 130 to 155, 160 is okay. 120 is a bit low, I think. 130 is better. Above 130. I mean, normal essentially is what we look. 30 to 155, 56 is okay. And actually, the real challenge comes from the other side for us, because often most of our patients are above 155.
Yeah.
So getting to about 155, 156 is, but 130 would be safer, I think. Yeah.
Given the complexity of the cases that we get nowadays, there must be a lot of confoundings, in most of the cases. Now the ancillary tests, you can't have even one false positive, right? either transcranial. There was a very recent study couple of weeks back. CT angio is around 90%.
So it was 4-vessel angiography.
Yeah,
4-vessel angiography, nothing else, nothing else is
that's the
foolproof.
invasive one you were saying.
Yeah, in the DSA.
Yeah, that,
So that's the gold standard. But yeah, if you find it positive, it's got good positive predictive value maybe. But if it is negative, if it turns out to show a flow a little bit or whatever, then you are in trouble. Which has happened to one of our cases.
so has anybody done a study of what percentage there are confounding so that you can't do an
Not aware.
Can you repeat the question for him? Because I would
What percentage of patients who have this confoundings and all this because of the complexity of cases, has people looked into it?
Not in the Indian scenario, sir.
Because the sort of list that we have shown, I'm sure, most of our patients will have some of the other problems.
So actually, I had discussion with him last time. We had one case who had cervical spine injury.
Yeah.
She
So you can't
had
do
this
anything.
traumatic brain injury, catastrophic
Yeah.
injury, but we could not go ahead with apnea testing. And my question was like, even if we want to do ancillary testing, our form 10 has no mention about the ancillary testings. The brain death testing in Sydney, they have clearly written, are you going for ancillary test? What was the contraindication for not to go ahead for the apnea testing? So we actually don't have that mentioned in our form 10.
Form is because it's not mentioned in the THOL Act, so that is the problem. Because the form is based on that Act. So I think that is the problem.
So what is the present practical ways to do a CT angio, and if that's a CT angio no flow, so that's the gold standard ancillary now almost?
That's the most pragmatic option.
Yeah, that's
Because
the, yeah.
4-vessel obviously is.
4 was
Yeah.
the gold standard.
So if the CT angio shows no flow, then we are.
I'll request Dr. Shroff to come in.
Yeah, so-
Now that you are here.
As per the law, as Sunil says, there's no provision in Form 10 for ancillary tests. So ancillary tests have actually no locus standi as such. Ancillary tests can be done just for your own comfort when you're not sure that this is brain death or not, but in our country, apnea test is the gold standard. There is no escape from that, and unfortunately, there are many cases we get missed. In government hospitals, sometimes they venture without an apnea test. That's where, Maastricht criteria 4 is so much useful. You just go ahead, you've got the consent, everything is ready, and you just go ahead. And yesterday I was showing slides, even abroad, 10% of your DCDs come from Maastricht criteria 4, whereas in India, we don't even consider that, forget about 3. So my first step would be always look at Maastricht criteria 4 and utilize that instrument to take it forward, because now one case you guys have done, you've shown the way forward, and I think, Doctor, there is a lot of leadership will be required, Dr. Seth, from you to make this happen, and of course, and Dr. Srikanth yesterday, I don't know, I heard about him, how hard he worked, he couldn't attend this meeting. All of us need to work as a team, and then we can make it happen. Thank you.
Thank you, Bhushan. Thank you, everyone. Bhushan
You may
filled in
have a
for
brainstem
Srikanth.
encephalitis or brainstem neoplasm. In that instance, you will have to do a 4-vessel angio. Apnea testing, it's a confounding factor. So that has happened. Recently I got a call from CMC Vellore. They had a young girl with brainstem encephalitis who had brain death, and there was family objection, for removal of the ventilator. So they contacted me, and they had done 4-vessel angio.
But that would be a contraindication to donation. That would be a contraindication to donation in any case, right?
No? It won't be a contraindication to donation, but it's a special situation where you can't do the apnea test.
Thank you, everybody. We'll go on to the next.
Calling our next speaker to please join us, Dr. Ashish Sharma, and he will be speaking about donation after circulatory death. Please.
So Ashish started from Chandigarh, 6 in the morning, reached at midnight here yesterday, I think. So thanks, Ashish, for taking all the trouble.
Yeah, thank you very much. At the outset, I would like to thank Dr. Avnish for carrying the torch of DCD throughout the country and congratulate him for his success. So I think a lot of it,
Our success, our NRP consortium worked very hard for 2 years.
yeah, I think, yes, we published and we ultimately, it was really heartwarming to see the outcome of this, right?
Very heartening, really.
So I think a lot of things have been discussed, so I'll just, we all know that organs have, there is a shortage and we have to get organs. I mean, living beings are not the best source. The disease, we are doing some brain death certifications, but we need to look into other sources. That is, if your heart stops, so can we take organs from there? So these are the different terminologies. Used to be called a non-heart beating donor, then donation after cardiac death, and people realize that you can actually do a heart transplant after cardiac death, so that terminology is not correct. They went on to circulatory arrest, that your circulation has stopped, but your organs are all right. And now it's called donation after circulatory determination of death, as compared to determination after donation after neurological determination of death, so as to differentiate the two. So the difference primarily is in the time, that you have a very limited time. Once your circulation stops, you have to get the organs as early as possible. There is a challenge in assessing the quality of organs. When the patient is brain dead, you can do all the kidney function test and your liver function test, and you know what you are going to deal with. Here, when the heart stops, you have a period of ischemia which is unpredictable, right? Whatever you do, you may end up with the organ which is not going to function, right? So that's the main scare which is not allowing this program to flourish in our country. Thankfully, we have technologies, we'll talk about it on later, where we can do that. So there are two things which are very important here. One is confirmation of death, and second is the safe removal of organs, right? And how do we confirm death? So we are used to doing it in our practice for all deaths. So, but here you have to show that you show absence of circulation either on your arterial line, which was patent before, your echo, or your asystole on ECG. So all these three, at least for a period of 5 minutes, right? So once you know 5 minutes, this 5-minute period is important, because it has been shown that if you do not have circulation in your brain for 5 minutes, there is no way you will regain a useful mental function afterwards. 3 minutes is the period, but to be on the safer side, they've taken to 5 minutes. But this is not a sacrosanct. You don't have to go through all the list of these countries. Most of the countries accept 5 minutes, but there are countries which have regulated this to as high as 20 to 30 minutes. For our country, the most of the opinion is sitting at around 5 minutes. So when we do this donations, so it can happen in a controlled or uncontrolled settings. Controlled means that you are actually withdrawing the life support. You know when you are going to withdraw it, and you know that after withdrawal, the cardiac arrest is going to happen. So that's a very controlled situation. You can arrange the logistics for donation, and then you can have an uncontrolled, unplanned, that the patient has an arrest, unexpected arrest, either in a setting of being tested for brain death, or just like that, or he's in emergency. So these are two situations, because your outcomes differ and your choice to do these donations and transplantation in these two situations differ. So just to give you an example, 32 years old with severe head injury, the brain matter is protruding out. So how many of sitting here will believe that this patient is going to survive? Show of hands. So virtually no, nobody, everybody knows this patient is going to die. Is there a point of keeping this patient in the ICU? So how many would actually keep him in the ICU on a ventilator? Show of hands. So nobody wants to. So what do we do with this patient? What do we do? So we have three choices here. We send the patient Lama, or we just he's in the ICU and he's come to the ED, and we keep go in the ICU, taper the inotopes. And third is we continue full support. So how many for the first choice, Lama, Dama? I mean, what's your practice here? We have a lot of intensivists sitting here. So what do we do here?
Usually Lama.
Yeah, so that is what is happening. Yes, right. So obviously you will not continue full support in such a situation. So you just either you just stop giving inotopes, or you send the patient to Lama. So that's not the right way of. Even if you go give full support, he is not going to make it, right? And if the injury is not severe, so severe that you may end up in a patient with a persistent vegetative state. That is probably worse than having a patient who's dead, right? One of my own cousins, right, he was admitted with severe brain injury, 22 years old. He's been now 15 years, and he's in his home on the bed and not able to do any communication, and so it's a very sad state of affairs. So we talked about the control situations where you withdraw. I mean, this situation, if you withdraw the support, you know that he's going to have a cardiac arrest. So if the cardiac arrest happens in the next 2 hours, 4 hours, or with NRP, probably you can prolong more. So then you can actually have the donation happening there, right? But if he has an arrest all of a sudden, then he becomes an uncontrolled without withdrawing the life support. So both situations are possible. So this is the original classification of Maastricht, which allows you to decide when and control and uncontrolled. So, and then there have been modifications. So we have a category 4, which has been talked about by Dr. Schroff, where the brain dead patients undergo cardiac arrest. So why is it important in our country is that a lot of brain deads will have a lot of electrolyte abnormalities, and they do end up having a cardiac arrest. There the donation pathway is already activated, right? You've already talked, there's already some communication going to the family regarding organ donation. So it's easy to get on to the wagon and get the organs out. So we've done those in our center, and I'll come to that. Control is still a gray area, again, where you have to withdraw support, you have to take permissions from the medical boards, primary medical board, secondary medical board. Despite the Supreme Court saying that these boards have to be there, I don't see them anywhere, not even in my hospital where I've been trying for the last many years. So you see in this slide that of organ donation, but this is organ donation after circulatory determination of death, and you see that countries like Spain are doing 10 per million only from this source, right? Not talking about brain death. So it is a useful source. We're still less than 1, even with the brain dead donation. The US does about 1/3 of donations from these category of patients. Same is for Australia. And the UK is even at higher, so about 44%, nearly half now coming from donation after cardiac death. And if you see the OPTN data, so nearly about 30,000 organs have been utilized, including lungs, heart, intestines, pancreas, apart from kidney remains the major organ to be used. So why is it getting more common across the world? Because we don't allow patients the intracranial tension to rise beyond a certain level. We do a decompressive craniotomy, so you are not going to have a brainstem herniation, you do not have brainstem death, so you are left with the severe brain injury, and you are there in the ICU. And we know that these patients are not going to make it. Either they will end up in a persistent vegetative state, or they'll just die off, so there's no point. And there are finances associated with this. There is expense. So there's actually futility of care. So we all talk about brain deaths, right? So if you see that less than 10% of patients with traumatic brain injuries actually end up having brain death. Whereas now we don't die at home, right? We are invariably dying in the hospital. This is an older data, about 15 years back. Still they report that 25% of community deaths are happening in the ICUs. And majority of these will have decision to limit therapy, which gives an opportunity. So if somebody is deciding to limit therapy, they will very easily understand and opt in for organ donation. So there we have a. So are we ready for it in India? Yes, in partly yes and partly no. So we'll talk about what are the challenges where we are. So category 4, Dr. Schroff said, is very easy. So you just have to just jump in and get the organs out, and you are all through. Control situations, we still are moving towards that, having our boards present there and getting all the certifications done, and then withdrawing the life support. We have the legal backing now because the Supreme Court last year, January, issued the guidelines how to proceed in this case. It's still a bit cumbersome, but if you want to follow it, you can still do it. So this is our paper which we were talking about, that we've sat for nearly 2 years, had various multiple meetings, thanks to Dr. Seth, who's been pioneering it, and there are all others have contributed, Dr. Mani, and he's also here. So Dr. Anil Kumar, Dr. Johari. So we've gone through all these protocols. We've made a lot of pathways. So I'll just skip these in interest of time. Maybe you can actually go through this in the paper. It's been published in various journals and being endorsed by nearly 8 or 9 societies across the country. So this is our program. So I think I'll just go to the results here. So in the interest of time. So this is our the first patient we actually ended up having one kidney which did not function. So that was a very severe setback. A patient with terminal lung disease, not a candidate for lung transplant, but they wanted a donation. So we just shifted at the time of after the arrest. We shifted him to theatre, and then we realized that okay, no, there's some. The ischemia time, warm ischemia time is very important here, right? So the one kidney never functioned. So that's a risk which nobody wants to take in today's times, right? Especially in the private sector. I mean, not in the private, in the government sector also. You don't want to do this, right? Doing all the surgery and then realizing that okay, you have to take the kidney out. Next 3 years we didn't dare to do it, and then we had another the type 4, the brain dead patient, who was absolutely otherwise healthy, normal kidney function, and we again dared to do it, and so this patient actually is now 10 years post-transplant, 11 years actually now, and if you see this is our database, so he maintains a creatinine of 1.0 after 11 years. So this is the kind of results you can actually achieve if you are doing it in the right way. So I'll just skip the surgical details. So these are the 19 donors which we published our data between from 2012 and 2020. So if you see that, except that they've required a prolonged hospital stay and dialysis, so otherwise the results have been fantastic. The long-term outcomes have been really great. And after the 2020, we've done 3 donations, including 1 pancreas donation as well. And all of them have done well. This is the trend of GFR over a period of time. So this is like long-term data showing a GFR of 61. This is primarily because all these donors were selected as in young patients with head injury, so no vascular disease, so their outcomes are going to be better once you cross the initial hurdles. So how do we move forward from here, right? So this is the flow chart again in our paper. So if you see that these are some terminologies, the agonal phase, the warm ischemia time, the functional warm ischemia time, which you have to understand. So the functional warm ischemia is the most critical part, that the moment your blood pressure drops to less than 50, so that is the time when your ischemic damage to the organ start, right? So that period has to be limited to ideally less than 2 hours if you are doing the normal DCD. But this is the game changer here, right? The normothermic perfusion. This is one of the reasons why the US is now doing more and more donations after cardiac death. And not only this, it has improved the utilization of other organs. Kidneys were already being done because we know that we have a support system for kidney. If the kidneys don't work, we can put the patient on dialysis. For the liver, there is nothing. For the heart and lungs. So this normothermic perfusion is the game changer now, which makes your DCD into a DBD type of thing. You need to have an assessment method. So even if you falter anywhere, so you need to have some assessment methods where you can actually you can assess the organs whether they are going to work or not. And these are some of the indications where if your ischemic time is prolonged, if you have a difficult retrieval, patchily perfused organ like this. So these are one of the first assessments we did. We didn't have any machine there. We just put the machine kidneys on the cardiopulmonary bypass circuit, and this patchily perfused organ within an hour or so became even worse, and we just discarded these organs. On the other hand, this is another patient where with the functional warm ischemia of more than 7 hours in an ICU, had a cardiac arrest, but the urine flow was there till the last 2 hours or so. Put the kidney on a normothermic machine perfusion, which is a little different from the regional perfusion, and it worked, and he's now 4 years and maintaining a normal creatinine. This is something we did about last month. We had an elderly donor, long-standing diabetes. We did a frozen showing type 2B diabetic nephropathy, and had a cardiac arrest while initiating a retrieval. Heparinization was missed, and when the kidneys came out, it was patchy, and nobody wanted to use it. So we thought while we are discarding, why don't we use it? We actually had a project initiated. I think that slide is missing. So yeah, so we had a project with the TTS research. So we perfused this organ just to see on the machine perfusion, normothermic perfusion, and the kidneys produce a lot of urine. So after the first kidney, we thought we should implant it. We implanted it. There was no second recipient available at that time. We once the first perfusion was over, we put the second kidney also into it, perfused for 6 hours. The total time exceeded more than I think 30 hours. The kidney still worked primarily, and the first recipient was discharged in 5 days with a creatinine of 0.8. The second recipient, unfortunately, the diabetic kidneys were big, so he had a compartment syndrome, has to be opened up again on day 5. We released the pressures and then the kidney worked and he was discharged with a creatinine of 1.5. So I think, summarizing, I think this is going to come up in a big way. I think we need to do it. And we definitely need to end the practice of sending patients lama dama. We let them die with dignity in the hospital and let them have the ability to exercise their choice of donating organs. We have withdrawal of care guidelines, we just need to put them into practice. And with these newer methods of NRP, NMP, I think that's like your fear of primary non-function is going to go away. And can we do it with our existing man force, or do we need a specialty of transplant? I am for it. I don't know how many of you sitting would be for it, but I think as we develop this more and more, I think we probably need more trained members. Thank you very much. And you need a very big team. Without that, I mean, you are nothing, right?
That's a wonderful summary of the state of the art. Ashish, any question? Please,
Dr. Ashish, what are the challenges with the heart in controlled DCD? I see that not many hearts are taken in controlled DCD.
So I think it's the readiness, this is the most important thing, and not all DCD situations would favor your heart donations as well. You may have a stroke patient who has a vascular disease, so the heart becomes unfit to your age. So heart is actually very selective.
I'll request Philip to comment on that.
Challenge before, that was overcome in Edinburgh Hospital. The initiation, pioneering work was done to 2015 in the UK. When you treat the heart, you reanimate the heart. Okay, that's how you preserve.
Absolutely.
You reanimate. So there we have